All right, so it's 8:01, so I'm going to get started. So good evening, everybody. Welcome to another edition of Hand in Focus. The theme for tonight is Flexor Tendon. And thank you so much for joining us tonight. My name is Harvey Chim from the University of Florida, and I'll be moderating this session together with Eberlin from Mass General Hospital. So the first paper that we'll be discussing tonight is entitled Reoperation Following Zone 2 Flexor Tendon Repair, and we have Dr. Neal joining us tonight. Next paper we'll be discussing tonight is entitled Revision of Flexor Tendon Repair, Factors Associated with Flexor Tenolysis, and we have Dr. Brent, DeGeorge joining us tonight. Our expert tonight is Dr. Lalonde, who's a professor of plastic surgery at Dalhousie University. Dr. Lalonde really can be considered the father of Lalonde surgery and is truly an expert in everything about flexor tendons. So we're truly privileged to have him join us tonight. Thank you so much for joining us. So again, just to rehash the format for tonight, we have two papers we'll be discussing, and we'll start with an author presentation, and subsequently residents and fellows from Dalhousie will just discuss the articles and how it will affect their new practice. Tonight we have Dr. Gudimella and Dr. Boudreau joining us. This will be followed by the expert discussion by Dr. Lalonde, followed by a short session of open Q&A. So please mute your microphones. Please ensure your camera off while the speakers are presenting. Cameras can be turned on for Q&A. Please ensure your Zoom screen name is your first and last name. And please ask questions through the chat function. We'll try our best to ensure that all questions are answered. And this session is really designed to be engaging and interactive. So without further ado, I'd like to invite Dr. Chen to start his presentation, and Carl will be moderating this first paper.
Great, thanks, Harvey. So Neal, we'll let you bring up your slides. I would like to echo the sentiment that we'd love to make this interactive. So if you have questions, please submit them through the chat function. We'll have Dr. Chen first, and then Dr. Gudimella, and then also Dr. Lalonde will shortly follow with his expert commentary. So Dr. Chen, take it away.
Great. Well, thank you everyone for having me here. It's a great honor to be here, and wanted to tell you really the story behind this article. I think that's the place that you can really get a flavor of why we're doing this and to get a sense of the structure of the article. So to give some background, I did my residency at the Harvard program in Mass General Hospital, as well as my hand fellowship. And during that time, the majority of the flexor tendon repairs were modified Kesslers. And we were aware that the MGH Plastic Hand Fellowship was a different fellowship at that time. And the Plastic Hand Fellows were performing modified Becker repairs or MGH repairs. And anecdotally, their results were much better than ours. And among all the therapy regimens, everybody used pretty much a modified Duran protocol. And so I graduated and I went away. I went to work at the University of Michigan, and then I went to Philadelphia, the Philadelphia Hand Center. And there, they saw the rehabilitation, the methods of flexor tendon repair. They were very different. And down below is Lee Osterman, who I still keep in very close touch with. And I learned so much from being there and learning about the way flexor tendons were repaired. And it was very different from my training. So in Philadelphia, from 2010 to 2014, we saw that the majority of the surgeons were doing cruciate repairs or Adelaide repairs. And the rehabilitation was primarily this early active or pyramid protocol that Gail Groth had described. And just seeing different patients cross-covering my colleagues, we were seeing that the outcomes seemed to be better. And so, we started saying, well, should I start doing modified Beckers? Because I was familiar with the MGH suture. There in Philly, they were venting pulleys, and I started adjusting things and changing my rehab. And subjectively, it felt like the outcomes were improving. So I came back to MGH in 2014, and there was this culture of looking back at what we were doing and really studying the outcomes. And we were studying different problems like scapholunate ligament dissociation, flexor tendon. We said, let's look at flexor tendon repairs. Let's look at other problems. And one of the great things that we have at our center is there's something called the Research Patient Data Registry. And basically, it's a giant registry where it pools the electronic records from multiple hospitals within our system. And so it contains the medical record as well as other data that's all contained in these giant arrays. And so you have more granularity than the traditional databases, but instead of having like single center case series, this allows you to pool larger amounts of data for more robust statistical analysis. So that was the foundation of this study. And so David Ring, who was at MGH for many, many years before becoming associate dean at the University of Texas at Austin Dale Medical School, David had a very good system of looking at these problems and looking at this registry. And he looked a lot at factors associated with unplanned reoperation. So we used the study designs that David had used traditionally, because you can find an unambiguous identifiable outcome, which is the reoperation. The reoperation you can identify very clearly within the record. And then you do a univariate analysis of the factors that you think might be reasonable to look at. And then you find factors that are significant and you put them into some type of multivariable analysis. And that helps you identify factors that are important in identifying this outcome or that are associated with this outcome occurring. So we began to look at all the factors, and when you read this paper, you see all the different factors that we're screening, and one of the factors was repair types. And we categorized this into 3 different groups: a modified Kessler, because they were very common, this MGH or modified Becker repair, because those were probably the second most common, as well as other repairs like a cruciate and different other elements. So what we saw, and this is kind of the heart of the results, is that when you ran this generalized estimated equation with the selected variables that we had identified, we saw that age, workman's compensation, and the Kessler versus non-Kessler repairs were significantly associated with unplanned reoperation. And so how do you interpret it? And this is going to be also discussed further in this session, is that we saw many reoperations for stiffness. That was the majority of reoperations. Some of them were for re-rupture, but also we saw that the majority of the rehabilitation was modified Durand, and they're most often used in conjunction with the modified Kessler repair. Sorry, that's a misspelling, with the modified Kessler repairs. And in this era, there was much less pulley venting. So why are we seeing these modified Kessler repairs coupled with modified Durands? Well, there's lack of confidence with the repair. So you're not sure if it's going to hold up to the stresses of surgery. So naturally, you're a little bit more conservative. So this paper really molded a lot of the ways that we approached flexor tendon surgery going forward. And so, we had the results of the paper before it's been published, but this has changed our technique. So now we do mostly MGH modified Becker repairs with epitendinous suture. Brigham Women's is doing an M-Tang. For mangling hand trauma, we still do modified Kesslers because we're trying to get the patient off the table, trying to get the hand revascularized. And then when we come back in 2015, we had added this early active protocol. And so you're starting to see that as Dr. Jupiter always emphasized that we should start thinking about our outcomes and studying our outcomes, we began to modify our practices according to it. So thank you for letting me share the story behind this paper, and let me pass it on to our next speaker.
Thank you, Neal. That was an excellent sort of backstory on the paper and early discussions results. I'd like to call Dr. Gudamella to comment for just a moment or two on his interpretation of this paper, and then we'll have Dr. Lalonde comment further. Rakesh.
Sounds good. Just one sec. Can I set up my screen share?
We're not seeing it yet, Rakesh.
As Rakesh is doing that, I would just say that the paper that Dr. Chen presented really is a historical look at the way tendon repairs were done for quite some time. And I think we've evolved quite a bit, which is what we're going to talk about. Go ahead, Rakesh.
Sorry about that. Can you guys see that now?
Yep, we got it.
Yes.
Perfect. Okay, so I just wanted to, so first of all, thanks so much for this opportunity to discuss this paper with y'all. So I just wanted to share some perspectives that I thought were practice changing for me in reading this paper. So first off the bat was the emphasis and the highlights of the paper in terms of multiple suturing techniques. So multiple suturing techniques were compared with their important clinical outcomes. In my general reading and throughout residency, I've come across lots of different types of suturing techniques and practices. And I think that the widely accepted practice is the modified Kessler repair. This is borne out in the study as well, with 77% of repairs being of this type. And this is true at our institution as well. This paper suggests an association between the modified Kessler repair and reoperation rates, and potentially supports the evidence to switch to a different technique. So that's something that kind of jumped out at me. And I looked at the two ones that I'd like to look more into are the modified Becker or MGH as discussed in the paper, and the MTANG repair that Dr. Lalonde, who's generally on the cutting edge, recommends as well. And the last thing was polyventing, and this is of some controversy at our center. Some of the surgeons support it, and others advocate actually totally against it with the concern of bowstringing. And while this wasn't reported in the majority of patients in the study, of the ones that it was reported in, 79% did not have reoperation. This wasn't a statistically significant result, but it was it still adds some significance in terms of clinical significance for polyventing. It seems to add to the evidence supporting that some venting of pulleys helps to reduce the risk of reoperation. And then this isn't something that's directly addressed in the paper, but it's something that occurred to me as I was reading it. I think it'd be a really good idea to keep a database with clinically important factors. I've listed some there that I picked up on in the paper to track the outcomes and generate valuable information for quality improvement. And at least we should do this for clinical problems where there's a large variability in practice and enough question about it. And a database keeping track of this can help us with quality improvement and outcomes research. And it's something that I'd like to implement in my practice. And I think in general, there's comfort in doing what's familiar, not considering the need for change. This is hard to do if there's no tracking or awareness of the outcomes or alternatives. So I really like how this paper touches on that. And I think it'll help us deliver care that's more evidence-based. So those are some thoughts that I had, and I'm happy to go through if there's any questions or feedback.
Thanks, Rakesh. Let's move on to Dr. Lalonde's expert commentary, and then we'll have some discussion.
Thank you. So excuse me here just a moment. I'm going to stop sharing for a sec.
I think as Dr. Lalonde brings up his video here, I think a couple of things that we're really going to have some discussion about are the nature of pulley venting, which was brought up in the chat, as well as the advent of testing your repair intraoperatively with using wide awake surgery. I think I'll speak personally and parenthetically that those two things have really changed my outcomes in my own practice, and I think they're really paramount to what we're doing in 2023. So hopefully we'll get the video up shortly, and we can move on.
Yeah, thanks so much for that. And I'm sorry that it's taken me just a sec here to get going, but I think we've got it now. So, okay, there we go. Thank you, Dr. Chim and the association for giving me the pleasure of discussing this great paper by Luca Bruin, Jonathan Lands, Frederick Wang, Kyle Eberlin, and Neal Chen of Boston. We learn more from our shortcomings than we do from our successes. That's why this is such a great paper, because it looks at the state of the art from the first 16 years of this century, from one of the best hand surgery centers of the world in Boston. My discussion will focus on how and why I think we can improve the outcomes so well presented here. I'd like to focus on the fact that 27% of the patients in this series ended up with stiff fingers. Half of them got tenolysis. Also, the overall rupture rate in 252 patients was 6%. I'd like to compare those results to the results of a paper by Dr. Jinbo Tang in 2017, where 300 cases had a 0.3% rupture and a 5% stiffness rate. The main differences in technique: all of the Chinese cases had full fist flexion and extension testing during the surgery, bulky repairs, generous pulley venting as required, all 6-strand repairs, all knots outside the repair, and all had up to half a fist of true active movement versus full fist place and hold in the Boston series. I really think they're on to something because I've been doing what they suggest and it really does work. Here's an example of why. This is a bulky 6-strand M-Tang repair where A4 is completely vented. We do full fist flexion and extension testing to make sure that there's no gap. Because the big problem here is that if you don't move at all, then the tendon gets stuck. And then you end up having another operation later called a tenolysis. We don't want to do that. If you move it too much, you're going to rip it apart. Because these stitches are only about 1/10 the strength of your tendon.
So you do this 10 times, so 9 more. So try to curl those fingers into that tuck position again, thinking about trying to curl the end joints down.
Nice.
Good.
Intraoperatively, there was no clinically significant bowstringing in spite of A4 pulley venting. And postoperatively, there's no clinically significant bowstringing at 3 months either. In this next case, I vented A1 and A2 in order to get full fist flexion and extension testing without impingement of my bulky repair. The repair is freely gliding and there was no clinically significant bowstringing during the surgery and no clinically significant bowstringing at 12 weeks after the surgery. It's time to forget the old don't vent A2 or A4 rule. The new rule should be vent just enough of any pulley, including A2 or A4, so the repair glides freely from unvented pulley to unvented pulley with active wallant movement, never more than a total of 1.5 to 2 centimeters to avoid clinically significant bowstringing. In full fist extension, you see the bulky repair at the distal unvented pulley. In full fist flexion, you see the bulky repair at the proximal unvented pulley. It glides freely from unvented pulley to unvented pulley. And you can make a good bulky repair so that you don't get gapping and it won't come apart. Because it's not hampered by pulleys, you're not going to need tenolysis. Here you see a grandma kiss repair that comes apart with the forces of active flexion that cause a gap. Bulky repairs don't get that as much. After surgery, true active movement has true gliding of the tendon. When we simulate full fist place and hold at surgery, you can see that the tendon buckles when we're halfway there. It doesn't actually move. And when we ask the patient to hold it, the tendon jerks, like right there. I think we need to focus more on good, strong repairs and proper pulley venting so those good, strong repairs will fit through.
Great. Thank you for those comments. We're going to open it up for some discussion. We have about 10 minutes. I would love to ask Dr. Lalonde, Dr. Chim, and Dr. DeGeorge really about some of the technical factors involved with flexor tendon repair. Dr. Lalonde, do you think that the number of strands matters? The type of suture matters? I mean, the actual type of repair matters, or do you think it's the pulley venting and the checking active motion matters more in the operating room? How do you think through those things?
Yeah, that's a great question. And I think that the Boston paper shows it. If you got a solid repair, it's going to do better. And frankly, I don't think it matters what kind of repair or what kind of suture, whether it's fiber wire, 3/0, 4/0, but it's got to be at least 4 strands. And I like the M-Tang 6-strand repair. And I don't think you ought to do knot poisoning where the tendon ends are trying to heal. And when you do these things with properly vented pulleys, the knots outside the repair don't get stuck. So it's just not an issue. And so let those tendons heal without knot poisoning. And I think that the main thing is a solid as rock repair. I think Jen Boateng's really onto something by saying it should be a little bit bulky, because if you start a little bit bulky, when they actively move it during surgery, the bulk seems to go away because the suture settles inside the tendon. And I think that the 2 key things because my repairs really sucked when I was a young surgeon, I got to tell you that. And wide awake surgery has improved things a lot because you get to test it and make sure it's not gapping so you don't get a rupture. But I think even more important than wide awake surgery is what Jen Boateng taught me about properly venting pulleys. You know, bowstringing is not cancer. Nobody ever died from bowstringing. And it's a theoretical problem. It's not a real problem. A lot of the studies are cadaver studies where the things are dehydrated and there's no blood in them. And, you know, like cadavers aren't humans, but wide awake patients are humans. And so we learn a lot from wide awake patients that we can't learn from cadavers. And yeah, they bowstring a little bit when you look and you're watching it move during surgery, but not enough that it's clinically significant. But a stuck finger is useless. And so we got to stop this bad marriage to you can't vent A2 or A4. And I feel very strongly about that because since I've stopped that marriage in my practice, my results are a lot better. So I think proper venting of A2 or A4, and you don't just whack out everything, you just take out just what you need. So with active movement during Wallant surgery, it goes from unvented pulley to unvented pulley. So really strong repairs, proper pulley venting, and testing your repair with active movement during the surgery, I think are really important. Whoops, you're muted, Kyle.
Yeah, I'm unmuted now. Dr. Chen, maybe you could share how your practice has changed based on these results and your experience.
Yeah, so I would say that I try to do one of the stronger repairs whenever I can. So I try biomechanically, when you look at the data, is that the modified Becker, the M-Tang really get a very strong repair that close to that resists physiologic loads. Whereas a modified Kessler, it's much weaker. So that speaks to how strong, I mean, that's one of the motivations of the paper, is that biomechanically you want to see if the clinical data lines up with the biomechanical data. And it certainly appears that way. I try to do a modified Becker whenever I can, an MGH repair whenever I can, just because it's really solid. I agree with Don about opening up venting those pulleys. I think that is really, really important. And it changed my practice pretty dramatically. So I think that you certainly, it is very valuable. The last thing I'd emphasize is the epitendinous suture. I do think that's very, very useful as well. And it's important not to underemphasize its importance.
Great. Dr. DeGeorge, any comments? And then we're going to go to the questions in the chat.
Yeah, I was addressing one of the questions in the chat previously. There was some talk about fear about Wallant surgery due to concomitant nerve injuries or concomitant arterial injuries that may take a little more time. I think Don's a master of sort of nomenclature, and Wallant has really kind of revolutionized what we do. And today, hearing about knot poisoning, he's a real wordsmith. We do a modification of Wallant in which we'll use local anesthesia containing epinephrine. We won't use a tourniquet, but we'll do these cases in the outpatient surgery center just because we have reasonable access to the operating room. And that way, the patients do receive some sedation, which I completely believe is not necessary for this procedure. However, I think it adds something to patient comfort. And then we're able to do everything in the operating room. Every case that we do, we test our repairs at the end. And I agree with Don in that we'll vent pulleys. All of our knots are on the outside, and that's how I was sort of trained. I think that's made our repairs better. I wanted to ask Don where he derived the 1.5 centimeter max for these things. It's so hard to study outside of a cadaver. Is that just kind of a rule of thumb, or?
No, I learned that from Jinbo Tang. And the 1.5 to 2 centimeters, 1.5 is if you got short, fat fingers like I do, especially my little finger. And, you know, at 2 centimeters, if you're a basketball player with long, skinny fingers, the kind that we all love to operate on because they do so much better. That's where the 1.5 to 2 came from. But really, it's not about the number. In my view, it's about you just vent just as much as you need. You incrementally vent. Like if you see that your repair is going to be right under A4, just got to do your repair. And then you can decide if you want to vent A3 or not, depending on what it looks like, if it's getting in the way or not. That's kind of how I look at it. I think it's good to do it incrementally. I see a question in the chat about somebody's worried about adrenaline if the arteries are cut. Look, the dorsal circulation is usually excellent enough, especially if you have young, healthy people, which is what most tendon repairs are. And even with both arteries cut, I have no hesitation to use adrenaline in the finger. If you got good arterial inflow, you got a nice, brisk capillary refill in your nail bed before the surgery, you're going to have it after the surgery unless you kill the blood supply with your surgery, which you're not likely to do. You're just in there to fix it.
I see a couple therapists in the chat and things like that. I think that's great. I think one of the strengths of our approach at UVA is our relationship with our therapists. So every patient that we operate on, we'll take a video of the repair and the motion at the end of the repair while the patient performs, and I will show that to the patient. And then I will also show it to the therapist. I think showing it to the patient allows the patient to know, hey, at point A, when the surgery is done, you're able to make a full fist. And then you should be able to do that if you cooperate with the therapist. And then the therapist seeing the repair, seeing the bulk, and kind of understand the motion parameters, I think helps them build confidence in an early active motion protocol.
I totally agree that taking a video and showing it to the patient and therapist is really important. I do that myself, and I found that immensely valuable. I want to spend the last minute or two asking Dr. Lalonde to share his pearls about postoperative therapy and whether that depends on the strength of the repair or what you see intraoperatively, or do you usually do kind of early active motion and kind of you can use it, but you can't, you can move it, but you can't use it type of therapy?
Right. Thank you for the question. So I think here's a really important pearl. I think, first of all, we ought to abandon full fist place and hold. Jinbo Tang has shown that full fist, it's the second half of a fist that's most likely to rupture. And so you don't need a full fist, you only need a half a fist. And true active movement, and Jinbo Tang tipped me into that too. He's taught me most everything I know, really. I know that is better. It's really improved my practice. But here's a really important pearl. I want to be there the first day the patient moves. So I did a flexor tendon repair yesterday on Monday. I want to be there on Friday, the first day it moves. Why? Because the first day it moves, 3 to 5 days after the surgery. So during the surgery, I preach to them, they got to keep it higher than their heart, and their hand is like a report card. I'll know on Friday when he comes in if he's kept it up, because it's not going to be swollen at all. If it looks like a football, he's been walking around like that and popping painkillers. So they know, they're waiting for me to see their report card when they come in on Friday. But what they have then is they have not started scar formation. It starts on day 3. So what they have in there is a fibrin clot. And sometimes patients or therapists are a little too timid to get them to bust through the fibrin clot. I know that I saw them do a full fist on Monday and, you know, opening and closing. So I know they can do a half a fist and it's not going to rupture my repair. That just makes sense. So I need to see them bust the fibrin clot. Friday, I need to see that guy bend his DIP. Because if you don't bust your repair through the fibrin clot, it's going to turn to scar. So if the surgeon's there to go, yep, no, don't be a wuss. I want to see that thing move. Good, great. Now we got the fibrin clot busted. Now just don't let it get stuck, okay? Like we talked about, and you can move it, but you can't use it. And just be really, really careful. Don't screw it up now. Don't go grabbing things and ripping it apart, because this is your best shot at winning. The same kind of thing I tell them during the surgery.
Great. I think we're going to, now that we're all in fear of not toxicity, we'll move on to the second paper. Dr. Chim, you're going to moderate that. So I think this was a great discussion, and we will move on.
Great. Thank you, Carl. That was really a great discussion, and I learned a lot of stuff myself. So moving on from this, we follow naturally into the second paper on Flexor Tenolysis. So I'd like to invite Dr. DeGeorge to discuss the paper, please. Brent, please.
All right. Can you see the presentation?
Yes,
Yep,
we see
you
it.
got it. You're good
Great.
now.
Thanks.
So yeah, thank you so much for including me in this. We're all honored to be here on this panel. I think this paper is a good jumping off point for discussion about tenolysis, and I think it'll serve us well today. The paper is entitled "Revision of Flexor Tendon Repair: Factors Associated with Flexor Tenolysis." Okay. So, the main philosophy behind this paper is that scar is the enemy of tendon repair. And in our hands, common causes for tendon adhesion is the nature of the injury itself, the zone of the injury involving tendon and the sheath, and then concomitant injured structures and some technical aspects of the operative procedure. A lot of this, at least in our preoperative counseling with the patients, is that, we want you to move early, and that, only half of the recovery is determined by the operation. The remainder of it's your interaction with our therapists. So we set that sort of standard early. We try not to immobilize folks regardless of concomitant nerve injuries. And then our postoperative motion protocol is an active protected range of motion protocol for all patients that are cooperative. In our hands, the indications for tenolysis are individualized based on our interaction with the patients, but inadequate range of motion in a finger for a given period of time is typically our starter. And this paper was essentially derived during a tenolysis procedure. When you're sitting there chipping away scar with one of your fellows, it's a great jumping off point for discussion. And we were wondering in a patient with concomitant nerve injury, whether immobilization had, in order to protect a nerve repair, had something to do with later rates of tenolysis. And Eduardo, the fellow involved there, is one of the authors of this paper. So in this paper, our study population, it was looking at all patients who had a flexor tendon repair of the hand or fingers. It was between 2010 and 2020 using a health insurance claims database called Pearl Diver. We used the first instance of a diagnosis of flexor tendon injury. And in order to meet the criteria for the paper, the patients had to be active in the database for 1 month prior to the injury and 18 months after the injury. And they needed valid age, sex, and comorbidity information. We then extracted data from these patients and their demographic factors on associated factors. And these include fractures, dislocations, foreign bodies, open injury, nerve, or vascular injuries. And then our primary endpoint was tenolysis. We wanted to know the rate of tenolysis in these patients. And then also we wanted to know if subsequent issues down the road with wound healing, with infection, or with tendon re-rupture influenced the decision to go back to the operating room. And then we analyzed those data looking specifically at whether a demographic or patient factor had anything to do with the rates of tenolysis, whether complications had anything to do with the rates of subsequent flexor tendon repair. So we had over 10,000 patients who had some form of injury. And then our rate of tenolysis in this patient population was 6%. Interestingly, in this patient cohort, there is no relationship between age, between sex, or between comorbidities and subsequent rates of tenolysis. And this is contrary to what has been published previously in small single-center studies that showed some relationship between age or with disease status, specifically smoking, with subsequent rates of tenolysis. When we looked at,
my name is Colton Booter, and I'm currently a PGY2 in plastic surgery at Dalhousie.
When we look at injury characteristics, concomitant injury of nerves was very common in our series, up to 6.4%. And then when we looked at post-operative diagnosis, flexor tendon rupture occurred in nearly 10% of these cases, which is interesting to hear some of the discussion from the first series regarding a bulky repair versus a granny repair. And then we can discuss how wallet may affect that. But tendon rupture, nerve injury, and wound healing problems are associated with subsequent rates of tenolysis. So in conclusion, factors associated with tenolysis, most commonly concomitant injury following flexor tendon repair, allow surgeons to risk stratify patients and help guide postoperative expectations. So really, if you have a patient with an associated nerve injury, it's my conception that you don't want to further immobilize that patient for fear that you will have some subsequent nerve healing issue. You're going to end up with a stiff finger that requires a tenolysis. And then as far as limitations, this is a database study, so it's only as good as the quality of the data that's been recorded. We don't have access to the granular data that was presented in the first paper by Dr. Chim and Dr. Eberlin. And there's no detail in this paper regarding therapy regimen or movement. One of the issues that we think is going to be interesting in subsequent analysis is whether race, demographic factors, or social determinants of health determine patient access to subsequent therapy. And that's one of the things that we're working on as an offshoot of this one. But I look forward to the discussion, and I want to give a special thanks to our authors on the paper, Alex, Thomas, Francis, Grace, Eduardo, and Bobby, who's always there for us. And I want to give a special thanks to whoever photoshopped this photo and essentially turned me into a meme at my institution. The mustache is awesome, and I thank you for that.
And thanks, Brent. That was great. Love the mustache.
Yeah.
Next, I'd like to invite Dr. Boudreau to discuss how this paper will affect your practice. Colton, please.
Sure. We had this pre-recorded. Thanks again for having me here. I think we're just getting the video up there.
Hello, my name is Colton Booter, and I'm currently a PGY2 in plastic surgery at Dalhousie in Halifax, Canada. I'd like to thank you all for this incredible opportunity to be here this evening. I'll be discussing a paper by Demers and al. Entitled Revision of Flexor Tendon Repair, Factors Associated with Flexor Tenolysis. I have no conflicts of interest to disclose. As an overview, this is a retrospective cohort study encompassing more than 10,000 patients that was published in Hand in December of 2022. The aim of this study are to assess the rates of tenolysis, but more importantly, outline various factors that are associated with the requirements for tenolysis post-tendon repair. I'll quickly go through a summary of the results. Regarding patient demographics, there were no identified demographics that were associated with tenolysis. With regard to injury characteristics preceding the flexor repair, a documented vascular injury was associated with increased tenolysis. Additionally, several post-op diagnoses or complications led to increased odds of tenolysis, and these included wound disruption, documented post-op nerve injury, tendon rupture, and need for secondary tendon repair. As junior residents, we're often focused on learning foundational information to appropriately educate patients and obtain consent for common procedures. We commonly quote need for further surgery, but sometimes don't take the time to think about what factors may be associated with increased odds of requiring further operative intervention. This study will help me tailor and refine my discussions with patients having flexor repairs based around the various factors discussed in this paper that may or may not be present for each individual patient. Finally, this study will also aid in guiding post-op monitoring and increase confidence in providing tenolysis as a potential management option for certain patients who present with factors outlined in this study's results. In summary, this is a very well-conducted study that is easy to interpret and will help guide practitioners with optimizing both patient education and management for flexor tendon injuries. Thank you for the opportunity again, and happy to answer any questions.
Great. Thank you so much. And next we'll have Dr. Lalonde, our expert, to give his take on this paper. Dr. Lalonde, please.
Yeah, thank you so much. It was a great.
Thank you for the privilege of discussing this great paper from Charlottesville by Alex Damaris, Thomas Moran, Francis Bustos, Grace Forster, Eduardo Natal, and Brent DeGeorge Jr. This is another wonderful paper from a great hand surgery center in Charlottesville, studying tenolysis in 612 patients who had it out of 10,000 repairs from 2010 to 2020. Again, in this paper, I'm going to focus on how we might improve our shortcomings. Tendon rupture is still the #1 problem, with 10% of the patients in this huge number rupturing. I suspect that most of the patients didn't have full fist flexion and extension testing during the surgery to reveal gaps so that they did not go on to rupture. I also suspect that most of the patients didn't have proper pulley venting, so the repairs get caught on the pulleys, and that can cause a rupture because of gapping. So what were some of the most common reasons for tenolysis? The most common was if the patient had a preoperative nerve injury. And part of the problem there was that they were immobilizing these repairs in many cases. And 3 weeks of immobilization is going to make your repair turn to rock. So I believe that if you repair a tendon and a nerve together, you definitely should move the tendon at 3 to 5 days after surgery. One thing that I love about this paper is that it shows how bad tenolysis is and why we should avoid it if at all possible. I mean, look at those complications. Repeat flexor tendon repair, 23%, tendon rupture, 22%, and then hematoma, nerve injury, infection, and disruption of wound. These are all things that we can avoid if we avoid tenolysis. So how might we avoid tenolysis? Look at these tenolyzed tendons. When we do a tenolysis, we take away all the strength of the repair because we take all the scar away. And we also take all the blood supply away. So these tendon repairs have no strength and no blood supply almost. So after you do a tenolysis, if you push a patient to do full fist flexion with great force really hard right after the surgery, what do you think is going to happen? It's going to rupture. There's no strength and there's no blood supply. So I believe we should treat it like a freshly repaired tendon. They can move it, but they can't use it. Remember that collagen formation doesn't start until day 3. They're not even going to make scar for the first 3 days. They just have a fibrin clot. So elevate and immobilize just like a freshly repaired flexor tendon. Let the internal bleeding stop. Blood turns to scar. And let the swelling go away to decrease the work of flexion. And let the patients get off all painkillers so that they can follow pain-guided therapy. So here's our same patient at 4 days post-op doing up to half a fist of true active movement, just like our flexor tendon repair protocol. And then by 6 weeks, she gradually comes into a full fist. Now here's another problem that I think surgeons get into. They do a repair, it looks great at the time of surgery, and they get the patient moving early, and the DIP joint is moving beautifully. At 2 weeks, they still have excellent gliding. And then at 4 weeks, the patient gets stuck. And so a lot of people want to jump in and do a tenolysis, but don't. Do the ultrasound. Show yourself that the finger is stuck. And then you start relative motion extension splinting instead of doing a tenolysis. By 4 weeks, the tendon is now gliding because you've placed an extra torque to separate profundus from superficialis. So this patient never needed a tenolysis. He just needed relative motion extension splinting. Another solution to avoid tenolysis is to make much shorter scars like Jinbo Tang taught me. This really works. If you make a short incision in the palm to push the tendon distally, instead of making a long incision all the way, you're going to get a lot less swelling and a lot less scarring and a lot less tenolysis. Look at how short these incisions are in this case. I knew exactly where the tendons were because I ultrasounded them. I carry my own ultrasound machine with me that I hook up to my iPhone so that I can tell where the tendon ends are, so I can make short incisions. And so that if they get stuck after surgery, I can tell whether or not they're ruptured or just stuck in scar.
Great. Thank you so much, Dr. Lalonde. That was really excellent. So some really good discussion points there. I want to start out with a simple discussion point for the panel. Do you immobilize after nerve or vascular repair? So I know that Dr. Lalonde, you and Brent, you do not immobilize, but how about you, Neal? Would you immobilize longer after you repair a nerve or artery, or you just mobilize it early?
It depends. So if it's these mangling hand traumas and a replant, that's different, obviously. But I think if you have a single artery and the other artery is intact, if you're just repairing it, that situation, I don't think you need to immobilize it. The nerve, if during the surgery, it's very mobile, it's very fresh, I think that it's kind of dealer's choice. I tend to immobilize those a little bit longer. I think that you're trying to weigh these different factors to decide how aggressive to be. If you decide that there's too much tension and you've placed a allograft across it, I think that in those cases, you can move them a little bit more aggressively because there's not the coaptations aren't under as much tension.
Yeah, I'll say I have no relationship with any of the nerve companies, but we liberally use nerve allograft, and we use Wallant. So at the end of all of our repairs, we can see that there's no tension on the nerve. We know the status of our tendon, so we will routinely move them early.
I think those are all great points. When I first started out, I tended to immobilize the finger for a pretty long time as well, but I've moved more towards gentle active range of motion. And I think another point to raise is, and we may have discussed this before as well, is I think it's good to have allograft, but you don't want to make the allograft too long as well because it can buckle when you flex the finger. So I'd like to ask the panel another question. What are your thoughts about flexor tenolysis? How often do you do it? And how many % of your patients do you do it? So Brent, could you tell us how often do you do flexor tenolysis and what are your indications?
For me, it's not all that common, and that's not to say that we get amazing results. We have a lot of patients who are, very interested at return to work, and I think often, there's the patient that you think you could improve, and you discuss it with them. They're like, well, it's good enough. So you get that patient that's got, near a reasonable motion, but their pulp to palm distance might be somewhere around 2 centimeters or so. And you tell them that there's a chance that you could make the better, but we'll need you to do a therapy protocol and this and that after. And I'm not great at getting those patients to undergo a tenolysis. So I think, some of it's access, some of it's concern regarding lost wages or lost time from work, but I don't end up doing a ton of tenolysis procedures, if I'm being honest.
Okay, how about you, Neal? Do you do tenolysis often?
I'm pretty conservative with them, and I think it varies among practice style. But I will say, interesting story. We have a therapist in our group, and we have patients, and once in a while she'll come up and tell me it's time, and intimating that we should do a tenolysis on the patients. And every time I do it, it works for those patients. So she has some knowledge or understanding of the patient factors, and has that sixth sense that she knows this is the patient that's going to do well with the tenolysis. So we have to study her brain, so she somehow knows.
I totally agree. It's so important to listen to your therapist. I do that all the time as well, and they can really predict which patients will improve. Dr. Lalonde, I know you said that the point you made about the relative extension splint, it's really such a great point, that I'm going to take and use in my practice. But do you ever do tenolysis in your practice? Given all the tips you just shared with us.
Yeah, so I guess the short answer is as little as possible. But there are some times when it is a good idea. And I also have a therapist who tells me when it's time. So I'm interested to hear that, Neal. But, here's how it's time. First of all, you got to have a good patient. Because if the patient let it get stuck the first time, they're going to let it get stuck again, and so there's got to be some kind of a change that's happening. Secondly, the tissues have to be really soft. When you feel the skin and it's hard as rock, do not go in there because you're just going to have more rock. It's got to be loose as a goose, because that reflects the tissues that are inside as well. So the skin is a reflection of the tendon inside, because the whole thing heals with the same collagen style. And most of these patients will respond either to relative motion extension splinting or CMMS. It's casting mobilization of stiffness. And so what the therapists do is they put them in a cast so that all they can move is the tips of their fingers. And because that's the only way they can use their hand, they move the tips of their fingers. And so it's another good technique. Therapists are very clever about these things. And so I think we all ought to be working with them for sure. So a therapist has to tell me it's a good idea. The tissues have to be soft. We've already had to have been through CMMS or relative motion extension splinting, and I got to have a great patient. But I can tell you that since I've started adopting these things that Jinbo Tang has taught me about venting pulleys properly and true active movement instead of full fist place and hold and all these other things, I almost never have to do it unless I inherit a patient who, like the one I showed you, she was cut when she was a little kid and she's stuck in scar. And so most of the time you don't need tenolysis.
Great, thank you. I really love your presentation, especially the part about ultrasound. I personally like ultrasound a lot, for flat planning, but I love if you could share some posts about ultrasound with our audience. What kind of settings do you use? What are your indications for it in the context of flexor tendons, preoperatively, intraoperatively, postoperatively?
Right. Thank you. That's a great question, because ultrasound has really improved my flexor tendon repair surgery. And I think that the point that I made in the video was quick, but it's really important. I've really shortened my incisions in the last 3 years, because it's only in the last 3 years that Jinbo finally got through to me that if you make short incisions, you're going to have less scarring. It's like, duh, So, and if you know exactly where the tendon ends are before the surgery, and if you carry your own ultrasound around, and I had a butterfly, the Clarius is better, it's wireless and it's got better visibility. It's almost as good as the real one we have in the clinic. So I just carry it with me. So on Monday, I ultrasounded that guy. I knew exactly where his tendons were. And so I draw it, and then I limit my incisions. So I have short incisions. So that's really number one, is shorter incisions, and ultrasound lets me do that. And then number two, you can actually see, like in 30 seconds, if the DIP stops moving, if the thing is ruptured, or if it's just stuck in scar. And if it's just stuck in scar, the other thing that's really nice for the therapists and for the surgeons, when you have your ultrasound in your clinic, or if I have it in my office, I get the patient to sit there and play with it for a while. And I let the patient look at his own tendon with ultrasound, and I go, see, look, you're moving. See that thing there? That's the tendon there. See, you feel like it's not moving, but guess what? It's moving. And so just do that a little more. So they're actually looking at their own tendon move inside the skin, which is pretty cool. And I think that that's helpful as well. And for all those reasons, I think in 10 years from now, if you're a real hand surgeon, you're going to have a ultrasound probe around your neck, just like cardiologists have a stethoscope today.
So are you ultrasounding every single patient pre-op as well to find the proximal and the distal tendon ends?
Yes, I am.
So every single patient gets the ultrasound pre-op and post-operatively on every single visit?
Correct. Well, not every single visit, but pre-op, I do it. It only takes 2 minutes. Like once you get used to it, I mean, you walk over to the fluoro machine, you take an x-ray. It's the same thing. You're just looking at soft tissues. All fluoro shows you is bones. This shows you your tendons, your nerves. It's like, hey, have a look. So yes, the answer is yes. But I don't ultrasound them with every visit, only if they get stuck, or if I think they need feedback.
That's great. So Brent and Neal, are you all using ultrasound in your practice as well?
So I don't have, I was actually talking to Don about this offline. We have a great relationship with our ultrasonographers. So I get pre-op ultrasounds on my patients and they mark the tendons on the skin prior to the surgery. But after talking to Don, you know, I'm interested in picking up my own device.
How about you, Neal?
Yeah, I'll order ultrasounds. I know Kyle has an ultrasound in his office, so I'm very jealous. But Don, it sounds like your setup is awesome. So hook it up from your phone. That sounds pretty good.
Well, it's not cheap. It's $7K if you buy the whole package. Like you can buy just the toy for $5K with no software. Oh, that's Canadian, so it's cheaper for you guys.
Yeah, you know, Colton had mentioned the idea of, you know, registry for this sort of stuff. I was wondering, Don, you know, Neal, et cetera. Is there a way, you know, I was particularly interested in, Don, your point about the size of and length of incision and sort of like area of exposure. Do you think from a research standpoint, there's some way that we could, you know, categorize length of our exposure, length of incision, or pulleys involved or something like that, and actually correlate some of these variables with our outcomes?
That's a really, really clever question and a really good idea, Brent, because I am so sick and tired of seeing yet another paper on a new technique, a new suture method, and a new, you know, that you're focusing on the right stuff. How much pulley are we venting? How long are the incisions? That's the kind of stuff that we ought to be looking at, and not another cadaver study in how strong this repair is.
There's a question in the chat about what kind of ultrasound do you recommend, but I think you answered that you use a Clarius ultrasound, right?
Yeah, and I'm not making any money on it. Too bad.
And you know, I have another question for the panel. What do y'all think about tendon wraps? You know, there's Tenoglide, you know, whatever else you might use around. Do you ever use it for tenolysis or any other indication at all?
I haven't used it. I haven't used it before. I have not used it before, so I don't really know.
We use it for tendon transfers and our sort of brachial plexus patients and things like that, but I don't use it in the hand or fingers.
And what about you, Dr. Lalonde?
I'm not sure how it improves healing. You know, I always like to look at things from a wound healing point of view. And a lot of the studies that I've seen, and even some of the experimental stuff that I did 1,000 years ago, when you put in a foreign body, you know, it actually hampers wound healing. And it you know, I don't know. I have a hard time understanding how that stuff is really going to help me. I think what I really need is a good, strong repair that I start moving early. I don't think that stuff around it is, maybe it is good. It just hasn't proven itself to me yet, and it still doesn't make sense.
Yeah, I totally agree. I don't use it for routine tendon repairs. I sometimes use it for tendon transfers like Brent does. But really, again, I'm not sure if I'm actually doing anything at all. So I think the jury is still out on that one. There's one last question I'd like to address from Stuart Proper. If anyone has had the opportunity to reopen a previously vented sheath, does the pulley regenerate? Does anybody have any idea on this? Dr. Lalonde, have you had to go back and look at a previously vented pulley?
I don't know the answer to that question.
Okay. I suppose it's good you have never had to go back and look at the pulley. That means you're probably doing the right thing.
I try to never go back if it's working.
Yeah. Okay. But anyway, you know, I think we've had a really great discussion. So I'd like to thank all our panelists, and I just have some closing slides. So yeah, so CME can now be claimed for hand in focus. Credits can be claimed once every 6 months for all webinars, 1 credit per webinar. And please look out for the email to claim your CME credits April to May of 2023. And thank you all for your participation. Please follow AHS on social media, and please look out for the next hand in focus. I really like to thank everybody for participating in the webinar tonight, our excellent panelists, our authors, our residents from Dalhousie, Dr. Lalonde, for your excellent discussion. This was really outstanding. I learned so much myself, you know, and from the discussion, and I hope the webinar was useful for everybody as well. So thank you again, everybody, and have a good night.
Thanks so much. Good night.
Good night, everybody.
Thank
Good night,
you,
everyone.
everyone. Thank you, panel.
Thank you.
Everyone, thank you.